Great. Hi, my name is Paul Wise from Stanford, and direct the Center for Policy, Outcomes, and Prevention at Stanford, and have been doing research on federal and state child health policies and programs for many years. And over the last few years, working with colleagues at Stanford, Dr. Lee Sanders, Lisa Chamberlain, sitting here in the front row, we have been focused on doing detailed analyses of health policies and programs in the state of California, and particularly the California Children's Services program. And I'd like to build on the data that are perspectives that have been presented by just focusing on just several distinct points, several elements that I think are critical and should be emphasized in a forum like this. And these few elements I've chosen, number one, because they represent highly effective programs that currently exist in this state, things that work. But not only do they work, they are highly vulnerable in current policy deliberation. I'm going to try to focus on those few elements that I think are worthy of special consideration here. The first thing to recognize, as David pointed out earlier, was the dramatic transformation that has taken place in the basic epidemiology of childhood in the United States. There's been a sharp reduction in serious acute, particularly infectious diseases, because of immunization and appropriate use of antibiotics. And as David mentioned, things that dominated our lives as residents are basically evaporated from modern pediatrics because of particularly immunizations and antibiotic therapy. At the same time, we've seen a growing concentration of pediatric action, hospitalization, mortality, and expenditure in children with chronic illness, in part because of a slow increase in the prevalence of these conditions, but also just because the other components that have dominated pediatrics for 100 years have largely disappeared. And we have, in many ways, a mismatch between our current systems of care and the current and emerging epidemiology that is creating significant problems and also opportunities to improve services in the state. The next thing to point out, however, is while there's been this growing concentration of pediatric action into chronic illness, children with chronic illness, that it's still relatively rare in children. And with all the discussion about children's special health care needs and chronic illness, we shouldn't lose sight of the fact that it's relatively rare, particularly when it's compared with adults. I hope you can see this, but it's also in the handout, that this is basically a map of chronic illness, functional disability based on age. This is the elderly, and these are little kids. And you can see that serious chronic illness in children is relatively rare as compared to older adults, and particularly in the elderly. And this sets up dramatic differences in the requirements of a healthcare system because of the differences in the prevalence of serious chronic illness. And the implications, number one, is that we need to really pay attention to how do we create high-quality services when we have highly scattered, relatively rare problems in a population, as opposed to in the elderly, in the adult world, where we have a lot more, a much higher prevalence of chronic problems. That in general, to provide high-quality services, people who have serious illness, you need a certain level of expertise, experience, investment in getting the right people, the right nurses, the right physicians, in the equipment and the systems that function to take care of people with serious illness. And because serious illness in kids are relatively rare, it has required systems of referral, the creation of regionalized systems of care that concentrates children with serious problems or kids who are seriously injured into designated specialty referral hospitals that are far more important in pediatrics than they are in adults. Because serious conditions in kids are relatively rare, there's a much more important requirement for concentrating service provision into regionalized centers. And all the data, all the research has shown that the creation of these regionalized networks of specialty care facilities in children has had a dramatic effect on reducing mortality and preventable morbidity in kids with serious illness. This has been one of the great advances of modern pediatrics, has been the creation of these regionalized systems of care for kids with serious health problems and serious injury. And the way that these systems are generally put together is that you basically have clusters of primary care programs, community hospitals that refer to regional specialty care centers, and these have been designated by the CCS program in California, and they are distributed throughout the state, but that draw upon virtually all constituencies, all areas of the state, and concentrate into these regional centers. Now, what's critical to understand about the CCS program, while it provides insurance for kids with special health care needs, that it has created the essential architecture for regionalized systems for specialized services in the state of California. It has created the formal mechanism by which these regionalized systems have been created. But what isn't often realized is that the architecture, the stability that the CCS program has created for these regionalized centers affects all kids in California, not only poor children. We need to recognize, like if I had a heart attack right here and now, most community hospitals would be very good at taking care of me. Why? Because they see a lot of guys my age with heart attacks. But when's the last time that a community hospital saw a 7-year-old with sickle cell disease and acute chest syndrome? Once every 4 or 5 years? Do you want a child with cystic fibrosis and acute decompensation going to a facility that has virtually no expertise in taking care of children with acute decompensation with cystic fibrosis? Of course not. And the CCS program has created an architecture, a stability for the regionalized systems that is crucial. And it affects not only kids in the CCS program, but it affects all children. It also affects kids who are privately insured. Just imagine for a moment what a pediatric trauma center for wealthy kids only would look like. You'd basically be sitting around watching TV most of the day. There would be no experience, no investment being made in the kinds of services, the kinds of people that need to take care of critically injured children. All children, the wealthiest children in the state, are now dependent on networks that have been stabilized and supported by the CCS program, which originally was created to provide coverage for only poor children. CCS has become a guarantor of regionalized specialty care services for all kids in the state, and that any alteration, revision, change in the CCS program needs to be done with great caution and great care, or else it has the potential to unravel these regional systems that are working extremely well in California. There are also opportunities that our data analyses are showing for greater efficiency and cost reduction in the CCS program. While there's much to protect, there's also opportunities to improve. And these are data that our center has generated, which basically shows that about 10% of all children account for about 2/3 of all the expenditures in the CCS program. This is more skewed expenditures than you see in the adult population. It's more than you see in Medicare. But this, while interesting, generates opportunity because it implies that we can improve services, reduce costs, create greater efficiency by addressing the needs of a relatively small group of children. That we have the capability to create greater efficiency and higher quality care by focusing on kids who are generating most of the action in the program. In sum, the critical challenges are, number one, to protect what is working in the CCS program, particularly regionalized specialty care, because there are no longer two systems of care. There's no such thing as a safety net system in the state for seriously ill kids and a privately insured wealthy program for wealthy kids in the state. Those programs have converged because of the changing epidemiology. That any erosion in what CCS is doing well will affect the quality of care for all kids. And we know that there are major opportunities. We can identify where those major opportunities for greater efficiency and improvements in the quality will be. Basically, the bottom line is there's a lot of good going on in the state of California for kids with special needs. There's also opportunities to make improvements. However, great care will need to be exercised for any revisions, any changes, any reforms, any budget cuts that affect the programs that are critical to meeting the needs of kids with special health care needs. That at a time when adult health care costs are dominating the debate, are dominating the policy concerns in this building, we have to be very concerned that adult health care is not merely applied to children. Their needs are different. The systems of care that have been developed in the state are different, and they need to be protected. We need to ensure that we respect the special requirements of children's health. I can guarantee that inattention to the special requirements of child health, if we ignore the special requirements of children, I can guarantee that children will die unnecessarily, and it will not only be poor children who will die from preventable causes in the state, it will be preventable deaths to all constituencies in the state. If the requirements of childhood are respected and embraced with informed purpose, however, I'm confident that we'll be able to build on what's working effectively in the state, improve services, and also reduce costs. By respecting the special requirements of children, California will regain its prominence as a model for providing critical services to kids with serious chronic illness and acute needs. Thanks.